All right, so good afternoon, everybody. If you haven't been on our past presentations, my name is Mark Driscoll. I am the program manager from the Ohio AAP for the Preventive Health Program. We've kind of been doing this series with a whole panel here. So we have our medical director, Dr. Chris Bulling, with us, Mary Renaud out of Dayton Children's, and then our speaker today, Dr. Eileen Chavez. I just wanted to mention one thing on my end in case we don't have time at the end to mention it, that after this series, the preventative health program will be moving on to a single standalone webinar on the results of the Youth Risk Behavior Survey out of the Ohio Department of Health. And that will be later in February. So I will send details out about how to register for that. And when that is in the email that I send with CME information, either later today or Monday. Um, and then that should be it for me. If you have any questions, please feel free to enter them into the chat or feel free to unmute if we have time for questions, and I will make sure that they get conveyed to Dr. Chavez and the panel. Otherwise, I will send it over to her and get us started. Thank you, Dr. Chavez.
You so much, Mark. So if you've been here before, I am still Eileen Chavez, and I am a pediatric psychologist working at Nationwide Children's Hospital and The Ohio State University. And I work in our Center for Healthy Weight and Nutrition there. So I work primarily with kids and teens that have obesity. And so today we are going to be talking about reflections. And we had to change the schedule a little bit. So this was originally supposed to be two, which I recognize I did not change that to say part three. This is actually the third session today. But the date is right. So that's good. Let me just go here. Okay. So no CME from any of us. Again, today is the third session. We would love it if you all would join us next week, February 13th, for the very last session where we're going to be trying to put everything back together, kind of give an overview of what we've already talked about and kind of steps to move forward after this. So just a little bit of quick review here at the beginning. Please know that when we talk about motivational interviewing, the whole point that we're kind of talking about it is to really help individuals and families kind of recognize what ambivalence is and where that ambivalence is for them. And ambivalence is really that feeling of being stuck between two different things. It could be two different choices, two different things that you would like to do. And that often creates cognitive dissonance, which just really means when we have a thought or a behavior that doesn't match a belief or a value that we already have, right? And so when this happens, we feel really stuck, or we've had to do something that doesn't really match the way that we would like to be doing things. We often feel very upset about it. We often feel very guilty or just worried, right? It creates a lot of anxiety. And so we then kind of engage in these defense mechanisms to kind of rationalize our choices or help justify why we're doing what we're doing. And so motivational interviewing kind of helps us identify that for people and reduce that discomfort between the different choices or behaviors that they're doing to help their choices and behaviors match their beliefs and values. So MI does this through four different processes. I know that we've talked about them in previous sessions, so I won't talk about them too much. But through all of these different four processes, we're really helping people think about change talk and we're reflecting that back to them. Okay, so today, like I said, we're going to be talking about reflections. So we're going to be learning what are reflective statements. Then we're going to be talking about how we can use them. We're going to be practicing a little bit. So feel free to practice in the chat or out loud if you're so inclined. And when we get to those places, I will stop everyone and give people time to kind of respond. And we're going to be talking about how we can reflect both feeling, content, and meaning in what people say. So before we really get started, I wanted to show an example of not so great reflections. So I'm going to play a brief video. It's about 4 minutes. I'm going to have to kind of go a minute in once I get it started. So give me just a second. And I'll pause. Can everybody hear the music when I turn that on? Yep. Okay. Let me get it to where I want it to be then.
We are not hearing it, Dr. Chavez.
Not
Oh,
getting audio.
darn it. Okay. Maybe when I share it, I have to share audio. So give me 1 second. Let me try that again. Yep, I think this is going to do it.
Just in the past year or
That's me.
so. Yeah. That's
Yep.
really a big problem. Yeah, it's pretty stressful for both of us. Ear infection.
Becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so. Yeah. That's really a big problem. Yeah, it's pretty stressful for both of us. He gets really upset. Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so, what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find, I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
By starting the interaction with an accusatory question, are you smoking?
Oh, I'm sorry. I accidentally unshared that again. Okay. Okay. Let me see if I just go. So, oh,
The provider immediately put this parent
maybe I have
defeated that this to bring an end to the uncomfort with
Come on
the
now.
both.
next slide. There we go. Okay. So now, after watching that, I want people to start to think about what did we notice? Feel free to, I have a bunch of different questions to kind of reflect on, so I'm just gonna hit all of them. And then feel free to feel free to think about one or more than one of these in the chat. So we want to think about what did we actually notice? What did you notice about the mom's body language, especially as the interaction went on? Do we feel like she felt heard or understood? Do you think she'd want to come back to us? And who did the majority of the talking? What do people think?
Well, the mom obviously felt very defensive, and I made me feel bad even watching the video. I felt bad. So just that she was just very accusatory and not really thinking through together how you can partner, but it was more just you're bad and you're doing this bad thing to your child. We know that parents want the best for their children, even if we all make bad choices that aren't ideal. But so yeah, just very accusatory.
Yeah. Yeah, and didn't feel really heard or understood at all. And one of the things the provider really didn't do was talk about mom's reasons for smoking, right? Like she didn't explore, like, what does smoking help you do? Does it help you de-stress? Because then we can actually talk about stress, right? Like what's causing stress in our life. We didn't find out the reason for why she was kind of smoking. Mark, is there anything in the chat?
Yeah, a few things. The first is that it felt like the mother was on the hot seat. She became defensive. And then there was kind of the implication that she was not caring appropriately for her child.
Yeah, yeah. And the most telling part for me, I think, is her body language at the end, where she's got like her arms crossed, and when they're like, "I need you to say you're not gonna smoke anymore," she's like, "Okay, whatever, okay," right? Which leads me to think, wow, she's not coming back to see us, right? um, okay, so that gives us like this is really I really wanted to show an example of kind of how not to do reflections, so that we could talk about other ways to kind of respond. And so reflections are really statements that kind of help us make sure that we are understanding a client or patient's experience and reflect it back to the client or patient so that they can feel heard and understood, and do that in a very genuine, non-threatening way. It also helps people be able to kind of explore their ideas more. I think about it as like a deepening, right? So we want them to be able to deepen their understanding of their own experience and the way that they're thinking, the way that they want things to be different for them, that change that they're kind of looking for. It helps people to really organize their thoughts, because a lot of times things just kind of feel like a jumble, or people may not have really explored their thoughts in as much depth as they are going to do when they're with us. So that way we can kind of help them recognize that change, or that wanting for change, right? One of the things that's been helpful for me to kind of recognize is that if I begin to reflect back a certain type of talk, I'll usually get more of that talk back. And so we can use that, because if we reflect back change talk, we're going to get more of that back. On the flip side, if we reflect back sustain talk, we're probably going to get more of that back too, right? So we just kind of want to help people understand how they're thinking, and the types of reflections we kind of put back out there are oftentimes what we're also going to receive. So the really cool thing about reflections is it allows us to build empathy, and support and rapport, helps people feel understood. I really truly do think that rapport and that therapeutic alliance that we develop with our patients is the foundation of all the work that we do with them. It is often the reason that people continue to come back to us, because it makes them feel seen, heard, and understood. It allows, like I said, like it allows us to have that deeper engagement. So it invites people to really think about their ideas, their experiences, their beliefs, their choices on a much more deep and nuanced level than maybe they've done with other people in their life or by themselves. It helps identify that change talk and helps people recognize that we're in this collaborative relationship together, and we will help support them in their desires to change. And all of that goes together to really help improve patient outcomes, because we're giving the autonomy back to the families and the patients. We're helping them recognize their own motivation for change, and through that then helping them get to a different place with their health. Okay. So what makes a reflection effective? Having an accurate and empathic reflection. And I want to just hit on that word accurate for just a second. And I think we talked about this the last time we were together last week. I would say sometimes we get things wrong, and that is okay, right? So our reflections, I don't want anyone to feel pressure that they always have to be accurate, right? We definitely want them to be genuine and empathic. But we may get it wrong, right? So as best we can do to make them accurate, that's great. But even if we get it wrong, that's okay. And I'll talk more about what to do again later on in this talk. But we definitely want them to be non-judgmental. And we're not just parroting back what people say. So as an example, if a patient says to us, "I'm tired of feeling sick," what could we say? People want to put a reflection in the chat, or feel free to unmute. What do people think? I'm tired of feeling sick.
Something like, it's so hard to always feel under the weather. Like, let's try to partner together and figure out how we can best help you, feel better more often, or be sick less often or something. I don't know.
Perfect. Thank you. Yeah. Like making sure that letting them know that you've heard them, right? Like it's so hard to always feel under the weather. And then that coming together, like how can we kind of work together to help you get to be where you want to be, right? Perfect. Anything in the
Getting a lot of good feeling reflections in the chat. This must be very hard and frustrating. It must feel so difficult to feel bad for so long.
Perfect. Love it. Excellent. So we're going to talk a little bit about the types of reflections that we can say back to people. So a simple reflection would be just saying the words back. We're just restating what they said. So you're tired of feeling sick. And then that kind of allows the patient or the client to go from there, right? A complex reflection is where we're going to add in some of that meaning or emotion, like what Dr. Bowling shared that comes out of the chat, right? So you're frustrated because it feels like what you're doing isn't getting you to be where you want to be with your health. And a double-sided reflection is one in which we kind of acknowledge that there is some ambivalence there. The people in front of us are wanting to make a change. So we might say something like, if someone has shared with us that they're smoking, kind of like that mom who we were just watching in the video, you really enjoy smoking, but you're worried about your health, right? And that kind of points out you really want to feel better, but you're also doing this thing that you enjoy, right? So I'm going to share one other video. This one is shorter, that shows different types of reflections and how we can use them with a statement that a patient is making. So this is with an older adolescent.
I've read so many different opinions about whether it's safe to use pot or not.
So you're hearing lots of conflicting information about the safety of pot.
I've read so many different opinions about whether pot is safe or not.
It's really confusing to read lots of conflicting information about pot, and you're not sure what to do.
I just can't imagine giving up smoking. It's been a part of my life for so long, and everyone keeps telling me I need to stop, but I just don't know what to do.
So on the one hand, smoking has been a comforting presence in your life for a long time and part of your routines. On the other hand, you recognize that you need to make some changes for your health.
Those were all very different interactions than the first video we saw. So now I want us to spend some time thinking about types of complex reflections. And the first one we're going to talk about is amplification. So I like to think about amplification as taking a bullhorn and kind of blowing up what a patient or family member has said so that it gets really big and kind of exaggerate it so they can really sort of see and hear what they are kind of putting out there. But the key to this is we need to be genuine again. and have no sarcasm, right? So as an example, if a parent would say to you, I don't think my son's anxiety is that bad. The way to use amplification then would be, again, to really sort of blow up or amplify that statement and say, so you're saying it's not affecting him in any way, right? And then the parent may respond, well, no, it's not affecting them, right? Or they may say something different, we don't know. But you're kind of making their statement bigger so that they can see it and then sort of reflect on it again. Coming alongside is where we sort of take whatever that client has said and articulate whatever it is on that side of no, right? So we're going to soften that sustained talk or respond to whatever that discord or dissonance is. So if someone would say to you, I can't give up vaping, I do it with my friends, you would then say, vaping's a big part of your life, right? So they have made a statement. We partner with them and say, yeah, I get it. That's a really big thing for you. That's a big part of your life. Okay, continuing the paragraph is where we sort of say the unspoken part of what someone is saying out loud. I think about it as kind of like saying that quiet part out loud, but we want it to be accurate as we can. We want to make a good faith guess at what they're trying to say. And we also recognize that what we're about to say is not words that they've said yet, right? So, but it's hopefully what they are thinking and meant to say. So as an example, if a parent would say to you, I've got to get my kids back, then the way to continue the paragraph would be to say, and you're ready to start making changes to do that, right? And obviously, you would use this type of reflection after people have told you a little bit more. It wouldn't just be in response to just this statement. But these type of reflections always start with some sort of conjunction, so and, because, but, etc., right? And then that gives a lovely opening for whoever's in front of you to say, yeah, I think I am ready to start making changes, or again, that sustained talk, I would really like to, I just don't know how, which is going to give you a little bit of that change talk too, right? But it's used to really help identify and cultivate that change. Reframing is a type of reflection that takes what someone else has said and sort of puts a different spin on it. I think about it like trying to help shift or change or repaint the picture that they're painting. Oftentimes around change or in a more sort of positive light. So as an example, this one would be if we were talking to an adolescent, I've tried to quit vaping a lot, but I always come back to it. Which they might think means that they're failing or they're quitting or they're quitting at trying or they're not doing well enough, right? But if we're going to reframe that, we would say something like, you are persistent. Even if you feel discouraged, this change must be really important for you to keep trying at it, right? Which just helps, again, sort of shift or change that focus. And then this reflection is actually called shifting focus, but the intent behind it is different than reframing. So shifting focus can be used when someone may be sort of argumentative or maybe in discord with you, and you were trying to let them know you totally understand where they are and where they're coming from. So an example of that might be, and I've had this happen to me before, where a teenager might say to me, what do you know about being big? Or what do you know about being in a larger body? You never had a weight problem, right? And I might respond by saying, yeah, it's really hard to imagine that I could understand, right? And the truth of it is, yeah, we're only ourselves. We are not other people. We don't have other people's experiences. So we don't know what they're really experiencing, but we can still try to understand, right? And so this lets people know, you're right. I don't understand because I'm not you. I don't have your experiences, but I am here. I am listening. I am hearing you, right? And then you can kind of go from there. Metaphor is one of my favorite reflections. And when I used to teach counseling skills to master's students, I used to say, When a patient or a client gives you a metaphor, it's like gold, right? Like you can use that all day long because it paints this really nice picture of their experience. And then you can kind of use that picture to talk about how they might want to make changes or how they might be able to make changes. So in this example, if someone says to you, like a teenager says to you or a parent says to you, this week has been crazy. It feels like I've just been crashing out all week. I couldn't hold anything anymore. They're painting a picture that might seem like a dam breaking or waves crashing on the shore or like waves hitting a wall, right? So you might respond by saying, you really hit a wall trying to figure everything out, right? And then we could go from there and continue to talk about how they might want to make different changes. Then the last type of complex reflection we're going to talk about is reflection of feeling. Which is the deepest form of reflection because it really helps people understand that you are understanding them and their experience. And so an example of that might be if someone says to you, if I don't lose weight, I won't be able to get my surgery and I could die. So a reflection of feeling would be, you feel so worried. Your weight is a matter of life and death to you, right? So we're reflecting back a lot of that worry, a lot of that anxiety, which they didn't say, but which kind of underlies their whole statement, right? And then people are like, oh yeah, I do feel really worried. And they might not have recognized the amount of anxiety that they were feeling, or they might have, right? But then they know that you feel it, you understand it, you've heard it. And then you can go from there. Okay. So I kind of mentioned this before, like what happens if we get it wrong? Can we get it wrong? Yes, we can totally get reflections wrong, right? um, so what can we do if we get it wrong? It's okay if we get it wrong. I always think of that. I'm going to go back to reframing here, right? But I just think of that as a golden opportunity to then try again and see if I can better understand my patient's experience, right? So I will often say before I put a reflection out there, I'll say, it sounds like that's often a really good way to start. It sounds like this is really hard for you and you feel really worried about it. And then I will say something like, is it okay if I share with you some of the things that I've been noticing? And please, if I get this wrong, just let me know. And then I usually say, because I get things wrong all the time, which is true. I get things wrong often, right? but I also say that in order to kind of let people know it's okay if I get it wrong, please. I'm not trying intentionally to get it wrong. And if I get it wrong, just let me know, right? And hopefully if you have that level of that foundational rapport, that level of trust, people will tell you that you got it wrong. And then you can share something like, one of the things I'm really noticing is that you want to make this change. You want to start eating different, but you don't know how your family is going to be able to afford to do that, right? I hear that all the time. And then if I get it right, families are like, yeah, that's exactly the way I feel. Or if I get it wrong, they're like, no, actually, that's not true. We could make changes. It's just that. And then they kind of go on from there, right? And if you get it wrong, it is okay to say, oh, I got it wrong. Please help me understand better. Could you tell me more about that? Or could you tell me more about how you feel? Or could you tell me more about your situation? And then make reflections from there, right? So some of the things that kind of get in our way when we're making reflections is just asking a lot of questions, right? And asking questions without kind of pausing to allow people to reflect on them or to respond in a way that it kind of feels like an interrogation. And oftentimes it's not done intentionally, right? We're not intending to kind of make somebody feel like they're on the spot. We're just maybe sometimes when you do this work, you find that you have to be comfortable with a certain level of silence. And you have to be able to sit in silence, even if it feels a little bit anxious or worrisome. And so sometimes if we're kind of uncomfortable or we're just kind of new at it because we haven't practiced it a lot, so like, let's be honest, silence can feel really uncomfortable. And so we might end up jumping in with questions just because we're like, oh, wait a minute, someone hasn't responded, right? And again, that is oftentimes unintentional on our part. We're not trying to make somebody feel like they're on the spot, but we jump in with another question to try to alleviate some of that anxiety in the air. But again, that can make people feel like we're not really listening to them or we're not kind of giving them that time to reflect and delve deeper in themselves. So I will say, I think sitting with silence is a really kind of important piece of reflecting too. So just kind of being comfortable with silence and when we ask our questions, allowing people time to kind of think about them, even if there is some silence, right? And the other thing I'll say is we can also reflect on the silence. Like if there's been silence for 30 seconds, a minute, whatever, we might say something like, this is a really hard thing to think about, or this is really challenging to think about, right? Or it's really hard to kind of put words to this, right? Like we can just reflect on that piece of it too. And that just adds another reflection and then people can be like, yeah, it is really hard. Misinterpreting meaning. And again, I should have put an asterisk on this, because it's okay to get things wrong. If we are inaccurate a lot of the time, people may feel like we are really not listening, and that could damage that therapeutic relationship or therapeutic alliance. Again, I feel like oftentimes this is very unintentional. But the way to kind of come back from that again is to say, well, then please help me understand, right? Because I don't think we're meaning to misinterpret. We just have to give ourselves sort of time and space to reflect back and really think about what are they trying to say to us in the moment, right? How are they feeling in the moment? And then the last one is just kind of doing reflections with a judgmental tone, which is definitely what we saw in that first video, right? Like you need to stop smoking. You should stop smoking. You should want to do this, which is all very judgmental. And that leads to people feeling very defensive and there being a lot of resistance. I see, Jose, I see you have your hand up.
Hi, can you hear me okay?
Perfect.
Okay, so I'm trying to sort out what I'm learning from you and tell me if I've got my assumptions incorrect. But first of all, I think that motivational interviewing is based in part or to a large part in behavioral theory. I hear the Rogerian part of today's presentation. So imagine on a continuum of helpers, I'm at the point at which I think someone like you refers to someone like me for more intensive intervention in outpatient therapy. I'm imagining that sequence. What happens when I get the patient is a description of your interaction as being an attempt to talk me, the patient, out of my problem. I go back to the referral source, your memory is that it went well. That's why you made the referral for further work. But from my perspective, the patient was being compliant and nice and going along with a current, either being pulled, probably the metaphor being pulled downstream, but they weren't 100% there. So that's what I'm trying to sort that out, integrate that, knowing something of what happens after your exchange that's like that, where it doesn't quite fit the story that I heard when I got the referral.
From like when a medical provider might refer to you for therapy?
Yes. A situation like that.
Chris, did you want to say something?
Yeah, I was going to say, I think that's a great observation, Jose, because I think one of the things that is really, you almost feel best as a provider, as a therapist, when somebody tells you, you know what, I don't really want to do that.
Right.
Like when you get rebuffed, because I don't view that as a negative. I view that as like, wow, they're really being honest with me. You
Correct.
know, when you talk with obesity providers, our colleagues in this area, especially with Eileen and me, you really get that back from providers like, I'm so glad when they tell me you're full of
Mhm.
garbage on this, because then we know they're being honest. They're
Yes.
not just, you're in the position of authority, I'm going to go right along with it. So
Yeah.
you're really trying to give them a lot of this is about giving them opportunity to do that.
Okay. Gotcha.
Also recognize that interactions like you just described are probably more common than we would like them to be. Right? And please know, I definitely have had patients tell me the exact same thing, right? Like they show up to their visit, and Chris and I both work in like tertiary obesity care, right? So they've probably been referred to us from like their primary care provider, right? And they show up and they're like, I don't know why I'm here. I just came, or they told me I needed to see you, right? Um, and they didn't necessarily want to be there, or maybe they did, or maybe they thought that it was just like they didn't really know why they were there. They were just listening to what their other medical provider said and they showed up, right? Um, but I think that gives us a golden opportunity again to use MI to understand what is going on for them in the moment, why they came. And I say that because I feel like there are so many demands on our time in life now that people only make time for what is important for them. And so if they're there, there's a little, like, I feel like I get a little tiny golden nugget, right? Of like, well, you're here, you came for a reason. I don't know what that reason is. But you could have just not come. And so there's probably something in here. And I would say the same, Jose, like if they're coming to you, like there's a reason that they came, even if they're like, I just felt like I was told to, and so I did, right? They didn't have to, but they did. And so using that to kind of use MI to help figure out like, and it is also okay if, you know, change is not possible at this moment.
Okay, so that leads me up to my next conflict in my head. So it would seem as though MI works better with a certain class of patient, um, in terms of where they're stuck. I'm assuming that MI works well when you've got a limited amount of time in a short window.
Yes.
I see clients in a wider window.
Yes.
And I think that I appreciate how long it takes someone to actually make change. So I'm wondering if you haven't said it yet, MI works best on a continuum of patients who are stuck. Those who what are characterized by what? Because I end up the ones that are characterized by so much resistance and fixation that it's going to take years.
Yeah, well, I would say I think and Chris and Mary, please feel free to pitch in here in 1 second too. I would say definitely MI works in very time limited settings. I think you can use it in other settings, but a lot of times it's used in more time limited brief settings.
Right.
You're seeing that person like over time. So if you think about like going to a primary care provider, you may see them over time, but the interactions are not going to be like a 45 to 50-minute hour. Do you know what I mean?
Right.
And I would also agree. Like, I think that MI helps people, it can help people make change, right? If they're at that readiness level, or it can help plant that seed for potentially making change down the road, right? Like the point of MI is not that we need to be changing or helping people make change all of the time. So even if we're just kind of helping to identify some of that ambivalence, they may then have another interaction with someone else at a later point in time where that seed kind of starts to sprout a little bit or take root. You know what I mean? So it doesn't
Yeah.
have to be like our goal is not to help people make lots of changes all at once. That is not our goal. Sorry, Chris.
Yeah, no, I agree. I think that there's some very interesting MI studies that even take place like in the emergency room. So those are definitely those short sort of things that you're talking about, Jose. But I also think there's some value for providers who see kids and patients over a long, long period of time. So,
Okay.
it's not about motivational interviewing is not about, I had someone say this is the way it is with dating too. It's about vector, not velocity. So direction is more important than speed. So rather than using your 15 minutes or your 10 minutes where you might build resistance or erect those walls, you're moving it just incrementally in the right direction.
Got it.
So the next time you see them, the advantage of being a pediatrician, of being a primary care doc, is you're going to see them over time. So if you move it just a little bit here and a little bit here, and they say, and then you get to the point where you're like, I want to talk about this more. Again, speaking from an obesity perspective, like, let's do one of those visits where we sit down and talk about this for a longer period of time. So I think that there's utility in longer term also, but you're absolutely right that your goal, the patients that this is meant for, is the movable middle. We always make a little bit of a caveat. You're not going to treat eating disorders with this. You're not going to treat acute psychosis with this. That's not what this is about. This is about the movable middle. And Mary, you were going to say something.
Yeah, I think definitely just reiterating what you guys have all said so far. I think that when I was trained in MI, I was presented with a like visual of the stages of change. And where MI fits the best is when we have patients who are in pre-contemplative and contemplative stage, and we're moving through that process right as we get to planning. And so I think what I'm hearing you say, Jose, is you have patients who come in, right, and they are maybe more in that pre-contemplative stage. And I think they're like, I love using my double-sided reflections in that moment of like, okay, so you feel there's a lot of pressure, external pressure for you to change, and at the same time, right, it sounds like you're not buying any of that, right? So whether it's a primary care physician or a parent that's bringing them into me, right, it's like, so like, this person really like you're hearing a lot of things about change from this person, and you're not buying any of it, you're not ready, kind of something like that. And what we're doing is we're just like helping for us to assess like where in that continuum of change are we, and if we're right, if the answer is we're like smack dab in pre-contemplative, right, we're not even thinking about change, then like asking kind of that open-ended question of like, okay, so like where do you want to move forward with like our time, right? Because maybe they have a change in mind that isn't what the referral is for, but they would still find beneficial. And oftentimes when I've done, so I've been in like longer term care with patients as well. And so it may take 6 or 7 months, right, for us to work on something that they feel like is important. And then, right, we can transition into maybe what the true referral was for, as we are able to kind of use MI periodically through that time, to help kind of increase that ambivalence, and to have them feel ready to approach that.
There's a lot of comments in the chat. I don't know, Mark, did you want to read any of them out before oh, Melanie, sorry, you've got your hand up.
Yeah, that's the excuse me, the one comment, so I will let Dr. Youngblood
Perfect.
speak to it.
Hi, I am struck by how much motivational interviewing works in just meeting a mom and a new baby or a mom and a new patient, because I've been learning a lot about infant and early childhood mental health, and it really struck me that what I'm doing is establishing myself as a non-knower and a non-expert, as opposed to I know everything about peds and you are here, not at my mercy, but you know what I mean, that there's a power differential. And
Mhm.
I really like how motivational interviewing equalizes the level where they are the expert in them, I am the expert in other things, and how can we team up and you teach me about you and what's important to you and what's important about your child. And I just love that. I love that I'm learning about this at the same time.
Aw,
Feeds each other.
thank you so much for that comment. I totally agree. I always come to my interactions with the families that I see, knowing that they are the experts on themselves and their kiddos and their families. And so oftentimes what I will say at the beginning of our interactions is that I'm not going to tell you what to do. That is not my job. I help you figure out what you want to do, or not do. And then if you do want to kind of move forward and make a change, we figure out how to make that doable and realistic in your life, right? Um, so thank you so much for your comment. I'm going to keep going. Okay. So now we've reached the point in time where we are going to practice a little bit together. And I'm going to share a couple different statements, and either out loud, if you want to unmute, or in the chat, just tell me how you would respond. Okay, so if somebody would say, I feel so tired, I just don't know what to do, how could we reflect back to that? Anything in the chat?
Not yet.
Not yet. Okay. What do people think?
Here's one. If you did not feel tired, what do you imagine you would need to do next?
Ah, nice. That's great.
It sounds like it is hard for you to feel so tired. Can you tell me more about that?
Great. Let's try another one. People keep telling me I need to stop smoking weed, but I don't know if I want to. How might we reflect that back?
Great one for a double-sided if someone wants to try that.
Any takers?
Well, it sounds like your friends are really concerned about you, but you're not really sure if you agree with them. And
Yeah.
That's great. Yeah. Yeah. Good. Oh, I see a lot of people in the chat.
Oh, good one. There's one that says you're not sure if you want to stop smoke. You're not sure if you want to stop. There's part of you imagining what it would be like without weed in your life. It's an
Those
interesting
are all
one.
great.
Yeah, that's a
Perfect.
very deep. It sounds like you enjoy smoking marijuana, but also acknowledge there are some concerns about it. Beautiful.
Good. Oh, excellent. Excellent, excellent. Sorry, I gotta move the box so I can read this one. I don't know where to start to make a change. How might we reflect that back?
Oh, this is a good one. It sounds like you're ready to talk about some changes you can make. So really sensing some change talk.
Good, 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 good.
And here's a little affirmatory one. You have started by verbalizing that thought of change.
I love it.
Yeah.
I was thinking about continuing the paragraph with this one, so I don't know where to start to make a change. And I might say, but it sounds like you really want to change, right? Beautiful.
That's kind of what there's another one here. That's exciting that you feel like you want to make changes. Is it okay if we brainstorm together? Really moving it right
Wonderful.
to action.
Excellent. So just kind of finishing today's talk up by thinking about the spirit of MI. And I know we review this at the end of all of these different sessions, but hopefully what everyone has noticed is that MI is very collaborative. Again, we are wanting to really partner and join with the person or the family that we're with, help them think about what they actually believe, what they value, what they want to do, and how they can kind of start to make changes if they're ready to do that. One of the things that I really love about MI is it gives that family or patient autonomy to be able to make their own changes. I feel like a lot of times people are told either by other family members or in other medical interactions, they're given like this laundry list of things that they like need to do, and it just feels really undoable, and that they don't have a lot of say in if they want to do it or how they would do it. So it gives them that autonomy to be able to make their own choices and their own decisions. And there's a lot of empathy and compassion in it, a lot of just genuine curiosity and being very non-judgmental in your interactions with your patients and your families. And so I'm going to end with questions. Did anyone else have any questions or thoughts that they kind of wanted to ask about?
Eileen, I had one question for you. There's, the one type of reflection is, they talk about like an amplified or as coming alongside sort of reflection. What's your thoughts on using those? Like, how do you use those?
Well, I think like for the amplified one, when I hear people really kind of saying things like, "Oh, I'm never going to be able to do that," right? That is a time that you can kind of amplify that and say like, it sounds like it's never going to happen for you, right? And that just makes it that bigger. And I hear that with like if you think about like joyful movement, like you're talking about moving your body more, and they're like, that's never going to happen for me. And then that's when you can kind of amplify that, and that coming alongside is really kind of helping people understand that you are always on their team. You are there, you are listening, you are trying to make sure that you're understanding them and their worldview and their thoughts and their feelings. And so, if somebody would say something like, I don't know, I can't get my child to eat vegetables, which I hear a lot. Me saying something like, it is really hard to get kids that age to try new foods, right? And letting them know you understand, and you're right there with them. And also it normalizes the way that they're thinking, right? Lots of people have that experience. Lots of kids have that challenge. So that's kind of how I use those.
Thank you.
Yeah,
Can I add a thought, Eileen?
sure, of course.
Okay. So I do a lot of work with students, counseling students and helping them build on some of these skills that we're talking about. And one of the things that I often see them do in their sessions is they move too quickly through the reflection into their open-ended question. And that's not necessarily a bad thing. But I think sometimes it doesn't allow that space for that patient to like either agree or disagree with the reflection. It's just kind of like, oh, like you're worried. How can we help with that today? And they're like, wait, I'm not worried. Like, and they feel like they're kind of like maybe pulled down the stream a little bit using Jose's metaphor. And so one thing that I would encourage folks, and I encourage my students to do this as well, is to like make sure that if you're offering a reflection, right, just giving even just like a moment of space for the patient to be able to kind of say like, yeah, that's true, or no, that's not, and offer that correction before we jump in with that next question. Because I think sometimes we get ahead of ourselves, because as providers, we love problem solving. We want to help our patients. And so it's coming from a good place. And right, like we want to make sure that we aren't moving too quickly through those.
And I'll just add to something that Mary said, because it made me think of something else when I work with students too. Totally second everything that she just said. The other thing that I have noticed that sometimes students will do is they will put two questions back to back, right? So they might make a reflection and then really quickly put two questions together. And both questions may be very equally valid, right? And they both may be lovely open-ended questions. But in reality, what that is going to do is that is only going to allow your patient or client or family to respond to the second question. And so that first one just kind of gets lost, right? So we've lost the reflection, we've lost that first question, and we're just now responding to this one here. So that again is really to just kind of second what Mary was saying is about like taking a second to pause and allowing people to kind of respond and then asking one open-ended question at a time, right? And it's okay if you do that double question thing. Just try to notice and catch it, and then come back around to maybe the first half of that question. Any other questions or comments or feedback? Melanie?
Hey, I don't mean to keep monopolizing the conversation, but this,
Oh, no,
I
you're
was
good.
never, ever 37 years ago trained in this. So this is immensely valuable. Thank you so much.
Thank you so much for being here.
I can relate, Melanie. I felt the same thing when I encountered it several years ago.
Thank you, everyone, for being here today. We really appreciate you being here and giving us your time.
I'll just jump in real quick and feel free if you have other questions to ask them. I'll just jump in real quick as I see people are leaving to say that I will send an email again with that link for applying for COME and MOC Part 2, as long as the invitation to our next webinar about the Youth Risk Behavior Survey. We'd love to have you all on that as well. And a big shout out and thank you to our panel for being here today, and to Dr. Chavez for presenting, and to the Ohio Department of Health for allowing us to put this on for everyone today. Again, we have a few minutes for questions, or you're welcome to head out, but we will stick around for a few minutes.